let's get started then.
Great.
Good evening. It's 7:02 Eastern Time. Greetings from New York City. We have about 17 inches of snow out there, and right now the temperature is about 34. I'm sure a lot of you have much better than us with all the snowstorm. Very pleased to tell you that we have a special session today. We have an excellent panel of experts, and this is all the work of Dr. Chase Heaton, who's going to introduce the panelists. Our focus today is oral cavity with a emphasis on management of the mandible. Chase, take it.
Great, thank you, Babak, and thank you, as always, to you and Mike for getting this set up. Let me just share my screen here. We have a really great panel for today. We have 3 case discussions just for introductions. My name is Chase Heaton. I'm from UCSF. We'll be presenting our first case. We also have my good friend, former co-resident, Dr. Ilya Likhtarov, with us. He did his training at Beth Israel and is now a partner at ENT Specialty Care. And then Dr. Avi Mantravati from University of Indiana, Mike's partner. He did his residency training where I did my medical school at Loyola in Chicago, and then fellowship at University of Miami. And 2 just amazing expert moderators for this session. One being my residency and fellowship mentor, Dr. Stephen Wong, who's now a professor at professor and chair at the University of Arizona. And then Dr. Jayden Shaw needs no introduction, and we're very happy to have him too. So I think we have 3 really good cases. There'll be a little bit of overlap, which is good, and just really excited to hear people's thoughts on these. So to get us started, for the first case, my patient is a 55-year-old, highly functional physical therapist here at UCSF. In February of 2018, she noticed some left jaw pain and bleeding, as well as some new numbness of the chin. There was just roughly a 1 centimeter mucosal mass near the retromolar trigone, kind of heaped up. A biopsy was performed, which showed mucoepidermoid carcinoma. Here's just a couple cuts from a scan that she had done. Just to get us started, I just want to hear what your thoughts are on this.
That's a great case. So let me ask the panel. So patient comes in, Dr. Wong, let's start with you. With the retromolar trigone and either a squame or, in this case, minor salivary gland, what is your usual workup? What kind of studies do you get for these patients?
Thanks. So yeah, I mean, I think that the most important thing in a retromolar trigone lesion or any lesion that's around the mandible, and obviously the focus of tonight, is whether there's involvement by the cancer mandible. And so getting once you have the biopsy done, but getting a CT scan with contrast, I think is a pretty good way to start to assess that. You can also oftentimes tell, I mean, sometimes just by physical exam, it's obvious if there's mandibular involvement or not. So a good physical exam and then supplement it with an imaging study to assess the mandible. So
let me ask you this. What are your views on getting MRIs in these cases, now that nowadays the MRIs have become cheaper and better?
Yeah, I mean, I think it's a little bit sort of, where you are. I mean, in some locations, that's a good way to go. Actually, when I was at UCSF, that was kind of the go-to thing. Here in Arizona, it's kind of CT scan is the more preferred choice of the radiologist to get, and it's frankly also quicker to get as well. So,
what about you, Dr. Shaw? I heard that you don't see patients without an MRI anymore.
Not quite true, but I think both these studies have different values. The CT is going to show you early bone changes and destruction or erosion of cortical bone. In contrast, MRI is going to show early invasion of bone marrow where the cortex may be intact. And you would see bone marrow which contains fat as white on the normal side, and the bone marrow that is infested with tumor will be grayish dark. And that's an early interpretation of bone marrow invasion, which you may miss on a CT scan. In addition, MRI will also show perineural invasion. So if there is tumor infiltrating along the nerve going up to V3 foramen valley, you should be able to see that better on MRI than CT scan. So if there is bone invasion, and particularly if the patient comes, this is a classical scenario. this patient started with pain and then went on to develop numbness, which implies that he had early infestation of the tumor into the nerve causing pain, and eventually the tumor killed the nerve causing numbness. And MRI would have been helpful early on, or even now you should be able to see perineural invasion on the MRI.
All right. Okay, so Chase.
Yeah, so I've answered many of the questions here, but you could see that this mental nerve is enlarged. So even though it's these in general are more slow growing possibly and kind of scallop away the bone, there is frank deep invasion here. So I think it's pretty obvious that this patient needs a segmental and not a marginal mandibulectomy.
Okay. So what's, Ilya, what's your routine when you have a patient that you have to do segmental? Do you get VSP for everybody nowadays?
I don't for that posterior defect. I wouldn't necessarily, especially if there's no tumor extension onto the buccal surface. I think since there's perineural invasion, I would be planning on resection of the entire inferior alveolar nerve. So come anterior to the mental foramina, and then make a cut between the coronoid and the condyle and just come down the ramus. That would be my plan for resection. But I would also try to get a margin on the inferior alveolar nerve at the skull base, to Dr. Shah's point.
Okay. So let me ask the panel, Dr. Wong and then Dr. Shah, how much do you chase perineural invasion? This is a great case because you actually see gross perineural invasion, but how aggressive are you in chasing these nerves? Dr. Wong?
Yeah, so here's where, I think Dr. Shaw made a great point in terms of how the MRI could be useful in terms of getting a sense beforehand, because you're going to get a better sense in terms of how extensive the perineural invasion is on the MRI. So if you see it actually tracking into the skull base, that's very helpful to know in advance. I mean, in general, I don't chase these into the skull base. I do just as Ilya described. Try to, when I know there's perineural involvement, either by the clinical exam or by the imaging, I do try to take it back to where it's exiting the skull base. But I don't think it's not been in my practice to go beyond that in terms of
Sure.
of going into the skull base with my surgical section.
So this is one of those questions that always comes up. Dr. Shah, what would you do?
So if you have, Babak, radiologically shown perineural invasion up to the foramen valley, then it doesn't make any sense to chase the nerve. So I would be inclined to secure a negative margin on V3 if the MRI is negative. It doesn't show any perineural invasion, where you have a potential of getting a negative margin on the stump of the nerve. But if you already have enhancement of the nerve at foramen valley, then it's a fait accompli, and chasing that nerve or taking out a segment of the extra osseous part of the nerve does not add to the radicality of the operation. Conversely, if the MRI is negative, patient has numbness, so there is nerve invasion, you have a potential of securing a negative margin on V3 by doing a segmental mandibulectomy, including the ascending ramus of the mandible above the entry of V3 into the ascending ramus.
Yeah, perfect. Okay, so I do apologize for all the experts if I need to sometimes cut short because we are at 20 minutes. Go ahead, Jeff.
I was just going to ask for a commentary on the role of neck dissection for this particular case, not from an axis of vessels, which I think a lot of us do a neck dissection for access, but specifically the role of oncologic reasons to do an elective neck dissection for a minor salivary gland tumor primary, whether you would do it or not do it in this case, and briefly just why.
So, Jeff, this is an interesting patient. This may not necessarily be a minor salivary gland tumor arising from the mucosa of the retromolar trigone. This may be a central salivary cancer arising from a tumor island or salivary cells isolated during development in the mandible, which eventually go on to develop what is called central salivary carcinoma. which actually arises in the mandible, not in the mucosa of the retromolar trigone. So this could be from a salivary rest within the mandible presenting as a central salivary carcinoma. In either case, the risk of nodal metastasis is low. This is a T1 mucosal mucoepidermal carcinoma, or it is a central salivary carcinoma, which is not staged because it remains within the confines of the bone. In both of those scenarios, the risk of occult metastasis is very low. So unless you are planning neck dissection or neck exploration for getting the vessels, or to do a segmental mandibulectomy for an en bloc resection, you may have to dissect at least level 1 to get soft tissue margin on the medial aspect of the mandible.
Yeah. Dr. Wang, would you do a neck dissection?
So I didn't catch in terms of the, this is mucoepidermal carcinoma, and was there any?
Mucoepidermal carcinoma with gross perineural invasion. And I didn't see the grading on the biopsy, but you know, we assume probably going to be high grade because it has that much of a perineural invasion.
Yeah. So I mean, I'll start with the easy. I mean, so you know, I think in cases where you have a T1 low grade mucoepidermoid in the oral cavity, no, I think the risk for metastasis is low, and I don't think a elective nodal dissection is necessary. I think, you know, I'm more inclined to do it as you go towards high grade. And, you know, like I said, in this case, it's a little bit easier because you're going to probably need to do some sort of neck dissection just in terms of access.
Yeah, I think most of us will be a little bit concerned about that gross amount of perineural invasion and err on the side of doing more neck dissecting than less. Okay, Chase?
Jeff, great question there. Obviously, as you see here, we did do a neck dissection. There's nothing high grade on the biopsy that really pushed us to do that. But since we were doing a flap, as many of us do, we kind of clear out that area just, of course, to find out if there's any occult nodal disease and make sure if there's a recurrence, it's not going to happen near a pedicle. So the defect was roughly 3 centimeters in size. So we're moving more towards the reconstruction phase of this surgery. I just want to get thoughts on people's
Sure. So Avi has been very quiet. Avi, what would you do?
I think with a segmental defect, obviously one of the first things we're looking at in our initial exam in the scans is what the patient's dentition is like, and getting a good establishment of what their long-term just expectations are, you know, as time goes on. And so this patient had, I think, a full set of dentition, if I'm not mistaken, at the outset, right, Chase?
Yes.
Yeah, so with a segmental resection, you're going to want a free flap, and obviously we would want something with reasonable bone stock. And this obviously comes up a lot as far as options that you have to offer to a patient versus what they actually pursue. So yeah, when it comes to reconstructive options, certainly fibula works great. And certainly when it's somebody who may be considering something like dental implants or dental rehabilitation later on, it obviously offers you some of the better bone stock available with minimal morbidity. So in this situation, I probably favor a fibula more so than other bony options.
So,
angios, okay.
And Chase, your defect is the body or the ramus?
We did a vertical cut, just as Ilya and Steve described, from angle up to the sigmoid notch, roughly to the mental foramen. So it's pretty much body only.
Yeah.
So
it's body only.
Chase, I was going to pick on you. A 3 centimeter bone defect is too small a defect for the extent of bone resection you need. You need to get it at least from the entry of V3 up to the mental foramen. And that would be clearly, easily 5-6 centimeter defect with a right angled segment or section on your fibula flap. So I'm surprised that the defect is only 3 centimeters.
Yeah, that could be a measurement error by me, but you can see a post-op picture here.
Yeah, that's that might be a little bit more than that. Might be California's 3 centimeter. It's like 5.
It should have been a 5. You can see here the reconstruction that was performed. We did go with an osteocutaneous fibula, one segment. And you can see here is pretty much angle to the mental foramen-ish.
So we're gonna save that for the rest of the case. Obviously, fibula is an excellent choice here. with everything. But future we're going to ask what if you don't have fibula or you're going to do something else. But there is a great question from the audience that I would like to bring up for the panel. Is imagine that this is perineural invasion, you have got negative margin, all nodes are negative. Would you radiate or not? Dr. Wang. All margins negative, tumor is out, all nodes negative, just PNI.
And was there invasion into the bone on the pathology? Is it a T4A?
Chase?
There was.
So I take as just like the PNI as a soft sign, but I think even more so if there's invasion of bone as a sign of increased aggressiveness, I would favor adjuvant radiation.
Dr. Shah?
Of course, you need post-op radiation, no question about that. But I'm reading that there is a positive margin.
Oh, there is a positive margin.
Yeah, this is a confusing path report in that there's no PNI, but there is a positive margin.
Okay.
I think so. No PNI tells you that the pathologist did not process the specimen well, because you had a clinical PNI.
Agreed.
And I would like to know where is the positive margin. And I'm inclined to think that the positive margin is going to be either in the bone marrow or the inferior alveolar nerve, either proximal or distal. So having said that, this patient, even before the surgery, would have required combined modality treatment because of the clinical presence of PNI, dilated or enlarged inferior alveolar canal, and the radiation port is going to be much higher than what you would normally think. I'm not worried about lymph nodes at level 4 or 5, but I'm more worried about proximal spread up to the foramen valley. So the primary port is going to be high enough to the base of the skull. And I would include the neck at least up to the lower border of the hyoid bone, implying levels 1, 2, and 3.
All right, very good. So if I'm gonna, Chase, do you have any other slides on this case?
Quite a few, but this has been a good discussion. So,
go ahead.
A lot of it is on more of some reconstructive complications afterwards. So I think we should continue with this and we could. Okay, so this patient did undergo radiation, completed in June of 2018. Wanted to get a little bit into ORN and how you manage that.
Okay, so let's ask Ilya and Avi, just quick succession. We have about 1 minute. You have your native mandible has ORN. What would you recommend?
So I'm most importantly, right off the bat, I want to make sure there's no tumor that's recurred. And sometimes that does take actually getting in, like making a mucosal incision, getting into the bone to verify that pathologically. Beyond that, a lot of that is based on what degree of clinical symptoms the patient's currently having. Are they having pain with it? Do they have a fistula? Do they have overlying skin changes? If they're otherwise doing okay, but they have pathologically proven ORN, I think it's very reasonable to start with conservative management, pentoxifylline, vitamin E, consideration of HBO in the interest of trying to delay bigger surgery so they get as far away from radiation as possible before proceeding.
Just curious, how successful have you been with conservative management in these cases?
It kind of depends on the degree of symptoms that they initially present with. I've had patients come in with just a little bit of exposed bone, no pain, no fracture, no fistula, no skin changes that have over time remucosalized. And I've had others that have just stayed steady for at least 1 to 2 years. And so even if they know that they're going to get surgery eventually, getting them as far away from their radiation time frame, you're still keeping an eye on them. So, with serial imaging, you're making sure that you're not progressing to the point that you're losing the condyle or something like that. That's much more significant from a reconstructive standpoint. But I think there's a number of patients that do quite well with conservative management. Not in this case, based on this image, of course.
Yeah.
I was going to say.
Yeah. That's just
that bone destruction looks like a 3 centimeter California.
Yeah.
So that's,
What's interesting about this scan is, or interesting to note, is the fibula is healthy. The ramus is healthy. It's really anteriorly where we see the ORN.
So go back on the previous frame. Okay, this is a very instructive X-ray. If you look at the site of section of your mandible and the exit of the mental nerve showing the mental foramen, that segment of the bone is relatively avascular.
Mhm.
Blood supply to the mandible is endosteal up to the mental foramen, and from anterior to the canine, you got plenty of crisscross blood supply from the other side. But posterior to the canine, it's entirely dependent on the inferior alveolar artery, which is gone because of the segmental mandibulectomy. So that segment of mandible between your bone suture or bone anastomosis and the mental foramen is avascular from endosteal blood supply, and I presume avascular also from the periosteal blood supply, because you must have raised a cheek flap to do the segmental mandibulectomy. So that segment is devoid of blood supply, except maybe a little bit coming from the lingual gingiva, and would be at high risk. Now, my second question is, this occurred within 2 years. So how sure you are that this is osteonecrosis? Have you ruled out recurrent tumor?
Biopsies were performed of some of the exposed bone and some of the tissue around it, and they were negative for cancer.
Fair enough, okay. But so I think, there is an explanation why that particular segment developed necrosis and not further anteriorly. And you can see that the necrosis begins at the stump and is going distal, and it'll probably stop at mental foramen. It won't go beyond that.
Yeah, a great point. Chase, want to just show you how you managed, and then we're going to move on.
Perfect. Yeah. So we did our best to treat her conservatively. It did not work. She really wanted implants. So we made the decision, obviously, to remove the osteonecrosed bone, but also the prior mandible or fibula segment in order to get implants. So did a new 2-segment healthy fibula to restore the whole hemimandible using VSP, which went very well. But of course, she had problems afterwards and developed exposed hardware. This is just a couple months ago now. She had very thin fibrotic skin, and again, tried to treat that conservatively and failed. Eventually had to take her to the OR just last week. And interestingly, what I noted after removing the bar was the fibula was healthy and it was healed to the angle of the mandible. This is a tough picture, but actually mid ramus, there was a fracture of the native bone. So I fear a little ORN or issues with the native bone left behind. But I covered that with a forearm and another reconstruction plate, and we're going to see what happens.
Thank you. Well, this is one of the most educational cases I have seen. And for all the audience and the fellows, these things will happen to you. You will see these cases, and these are super challenging. I really thank Chase for bringing up this case. And this really, we can talk the entire hour about this one case and how much you can learn from this, because these things really have happened to me, it happened to all of us. But in the interest of time, we're going to move on. And Ilya and Avi, if you have comments about Chase case during your presentation, please feel free to go. All right, who's next?
I believe I'm next. So let me just share my screen. Hold on one second.
I just have a quick question, I guess, while Ilya's getting his slides up. Does anybody in the group mini plate fibulas or mini plate mandibles at all, as opposed to larger recon bars, particularly in the post-radiated setting? I know there's some around the country that do, just to decrease the profile and some of that thinner fibrotic skin. I just didn't know if that was something that people consider.
That's a great question. We don't at NYU, we always use the recon bars, but I think that's a very valid point.
Yeah, Avi, we spent about 20 minutes in the OR looking at the segments and deciding whether to put a mini plate or place a new large recon bar. And we bent a plate to the prior VSP plate to get the same profile.
Yeah, perfect.
So I'll move on to my case. The one comment I would have about Chase's case is when I see that kind of ORN and I worry a little bit about more progression of ORN, I'm always worried about burning the second fibula, because if the patient progresses to have the entire arch diseased or the ramus diseased, then and you need a really long segment of bone for more total reconstruction, then you kind of run out. And I understand the desire for dental implants, but I probably would have put a scapula and saved the fibula for later. I don't know if that's too cautious, but just
Talking like a true recon surgeon. Save my fibula. Okay. I think that's a great point. I agree with that. All right.
all right. So my case is a 65-year-old healthy gentleman, never smoker. He was initially treated for a T2N0 P16 negative squamous cell carcinoma of the left palate with primary radiation. He finished that 5 years ago. Then 4 years ago, he had recurrence along the left retromolar trigone. And I didn't see him during those presentations, but reviewing his scans, I suspect it was contiguous tumor. So palate was a little more lateral, and then likely just a marginal recurrence into the ipsilateral retromolar trigone. So at that time, he went through a left marginal mandibulectomy, neck dissection, and radioform reconstruction of the retromolar trigone defect, a little bit of a buccal defect. The pathology at that time showed tumor invasion into bone, so T4A. There was one lymph node. Margins were negative. And so he presented to me at the end of last year. You could
Can you just explain a little bit more about the indications for a marginal and not a segmental of the first surgery?
I can't comment on that. This wasn't a decision I made, but looking at his scan, there was scalloping similar to your case. There wasn't any widening of the inferior alveolar canal. And it was truly retromolar where there's a significant bone height. So I suspect that the resecting surgeons felt they could get away with negative margins, which they did.
Mm-hmm. Doctors Wong and Shaw with the history of radiation.
So I think, the initial primary was on the soft palate. And what would be at risk would be the coronoid process and the anterior rim of the ascending ramus more than the body of the mandible. So based on the clinical location, if the disease does not violate or the operation does not violate endosteal blood supply, then I have no problem doing marginal in a post-radiated patient. And I have a feeling they probably took the coronoid process and the anterior rim of the mandible, keeping the mandibular canal intact, therefore the endosteal blood supply intact.
Dr. Wong?
Yeah, it's hard to comment without seeing what the imaging looked like in 2016, but I kind of agree. I was a bit surprised that there was there actually was bony invasion. I mean, sometimes when you see marginal mandibulectomy, it's a little bit of a just sort of like an extra precaution. But if there was in fact bone involvement, if it was in an area that was more sort of in the coronoid and on the retromolar trigone, such that you could save sufficient bone along the aspect of it, then it probably was reasonable to do.
Yeah, I think what all of the panelists are saying, and this is for all the audience, is, obviously this is doable, but if you're starting, you have a patient with recurrent cancer with prior radiation, there's nothing wrong about being more cautious and don't trust that mandible and just do a segmental, do a clean operation and be done. Obviously, you can do marginal, and that can be done as Ilya said in the posterior. But personally, I think those should be the exception, not the rule. All right, Ilya, continue.
Does anyone plate that mandible after a marginal?
That's a great question. Anybody does a prophylactic plating? I'm a Toronto guy, so we used to do a ton of those, but I think we don't do it.
I've done it in the past. I haven't done it recently. I worry about whether that's going to helpful or I'm going to risk having a plate exposure. So I haven't done it in a while, but I have done it in the past.
Avi, would you do a prophylactic plating?
I probably wouldn't, especially if he's got teeth. I don't know. We don't have all the slices here, but chances are the vertical height of his mandible is adequate to support a marginal alone. I think it's.
Here's a scan prior to the surgery that I did. So I think they saved the coronoid, and you can sort of see the height right there at the angle a little bit. But
so the marginal is from the body of the mandible, correct?
Well, it's truly a retromolar trigone, sort of
Okay.
it almost looks like a little of a V cutout of the retromolar
Okay.
trigone and some posterior body.
This looks like a New York studio apartment. They're so small. Well, how much did they take?
Well, it looks like they took out everything. Here, hold on a second. This is where I saw him, and you can see the new tumor. This is the fall of last year. You can't see the forearm, but it really starts right behind here. So here's his, you know, essentially they took out his molar teeth and the posterior ramus at the angle, at the retromolar trigone.
Okay. So let's ask Avi. This is patient. What would you recommend here?
I think there's no question he would need a segmental at this point in time. He has,
Okay.
Tumor in a previously operated mandible that's already had its vertical height lowered and previously radiated field. You're running out of treatment options in general, and he still has an opportunity for definitive salvage surgery. In this situation, I would certainly be planning for kind of one last hurrah as far as doing a wider definitive resection, including segmental mandible.
I agree. So let me ask, anybody would do less than segmental here? No. Okay, Ilya.
Yeah. So you can see his tumor. He doesn't have any numbness, mental nerve numbness. Here's his PET scan, really just an isolated disease to the lateral cortex. A lot of dental artifact, but on his contrast CT evaluating for bone invasion, I didn't see any frank bony destruction, but for reasons that were discussed, because it's radiated site, because the site is already lowered posteriorly, I elected to do a segmental resection. These are his preoperative films. And so a lot of the questions have been discussed. Would you pull the teeth and just resect the gingiva? Or would you do a marginal and then put a plate? Or would you do a segmental? I selected to do a segmental. Sounds like most people would do the same. And so he went through left segmental resection. I resected all of the previously marginal component of the mandible. And so his path was T1, no bone invasion, 1.5 centimeter tumor with 2 millimeters of invasion. And, I don't feel bad about what I did in retrospect, but I just thought this is the one case where he probably would have done okay with a local invasion, but I think there were definite reasons to go forward with a segmental resection.
Okay, so let's ask the panel. Dr. Wong, can you go back to your clinical picture? How would you approach these tumors? And obviously this is a case that, as Ilya said, it's really difficult. Would you just say, I'm just going to do clean, or how would you approach these? How would you design your resection for these kind of tumors?
And so, I think the other point, in addition to all the other things in terms of it being recurrence, in terms of being press-rated, but I think tumor, right against those molars, and that's an easy access to get deeper into into the mandible, which sometimes doesn't always show up on the imaging. So I agree with Ilya's decision to do a segmental, I think I would, the segment of mandible that would include kind of coming anterior to where I see the tumor around those molars.
Okay, and in terms of margin, how would you decide on your margins, and what's your usual go-to? Is it in the OR? Is it you look at the imaging? How do you decide how much you want to resect?
Yeah, it's all those things, but it's also in a lot of ways I tend my thought also on Chase's case. I'm generally inclined that if I know I have to take part of the inferior alveolar canal, that I'll probably take the whole thing and come, all the way forward to the parasymphysis. Because I think functionally it's not a whole lot different. That's kind of a straight segment. So I'll usually take the body segment if I know I have to take part of it. So, so this case, I think I would have done pretty similar cuts to what Ilya showed on this in terms of, it looks like he went from pretty much the angle and then taking the body segment of the mandible.
Dr. Shah, how would you design your resection around these
So
tumors?
this is a small mucosal cancer in the wrong location. It is sitting on the attached gingiva right up to the insertion of the tooth. If this was a lesion on the buccal mucosa, a simple per-oral excision, or if this was the lesion on the tongue, it would have been a simple per-oral partial glossectomy. But this is a small tumor in a wrong location. And therefore, I think what Ilya did is the right thing. It looks like a big operation for a small tumor, but the tumor is in the wrong place. And that is what mandates the need for a segmental mandibulectomy. I would not extract the teeth and do a marginal. It's an absolute no-no. You have a radiated mandible. You are extracting the teeth on a tumor which is already on the attached gingiva, where there is a potential of the tumor creeping into the tooth socket. And you are inviting trouble both ways from the point of view of recurrent tumor as well as bone necrosis. And the only thing you can save is the condylar head for anastomosing your fibula. But then the rest of the ascending ramus has to come out, including the previous radial forearm flap.
So I'm curious
So
for the,
I would, thank you. Yeah,
I'm curious for the panel. I'm reading this case as a marginal recurrence of his original cancer, that you sort of marched along the margins here. You're within the 5 years. So assuming this is not a second primary and is related, and it's from his original cancer, and you've done the segmental and a resection of the old flap, would there be a consideration, would some of you consider adjuvant radiation for a potentially third-time recurrence for this, given that you've resected all the probably radiated area, it was previously more in the soft palate, and maybe the concern is just the mandible, but I'm curious how many of you would advocate for adjuvant radiation after your resection if you bill this as a third-time marginal recurrence of the existing disease?
Dr. Wong, would you re-radiate?
So, I think it's a consideration. The pathology report looked actually pretty good to me. So, unless there was some other negative prognostic factor, I probably wouldn't. Probably because he may recur again, and then then at that point I might pull the trigger. But from what I see on the pathology report on this one, I probably would observe at this time.
Dr. Shah, observe, radiate.
Jeff, you are making a good point, but if you look at this lesion, this is a strictly mucosal process. There is nothing at the, I don't know the details of the path report, but I presume there was no tumor under the flap into the bed of previous resection. There is no bone destruction here. So to think of this as a local recurrence, yes, it's possible. But I am more inclined to think of this as a new primary tumor, or maybe strictly mucosal recurrence extending along the mucosa without any bone invasion. And if the margins are negative, I would be inclined to stay put, because you would be re-radiating the oropharynx now to a full therapeutic dose. And I'm not worried about the ipsilateral side, but I'm worried about the angle of the contralateral mandible, which will wind up getting double dose, and you will get radionecrosis of the opposite side of the mandible.
Yep. So we got 1 minute. Ilya, want to finish your case?
No, that was it.
That was it. Perfect. Again, thank you. Great case. So much to learn. For all the audience, I'm just going to say my thing. I hate re-radiation. It's devil, and you and I have to take care of it. So as much as I can, no. And I agree with the panel that I would not re-radiate. Okay, Avi, you're up.
All right. Thanks. I would just, while I'm getting these slides up, I would agree. I tend to really shy away from re-radiation. I don't know that it necessarily has the best of data outcomes. And
we also have Dr. Don Reed on the call. And Don, if you, at any point you would like to make a comment, please let us know.
Just enjoying the show. Great.
Okay. The cases are excellent.
Babak, is this showing up okay on your end?
Yeah.
Okay, so I have a 80-year-old female who came in with a lesion of her left gingivobuccal sulcus, and she essentially had 6-month history of progressive pain in that area, no numbness. She's a lifetime non-smoker, non-drinker. She's otherwise healthy, and she essentially had this exophytic lesion that was arising within the gingivobuccal sulcus itself. And on her initial presentation here, it was in pretty close proximity to the skin, extended from the mucosal side up to the oral commissure. It looked like it was creeping up onto the gingiva, but was actually entirely mobile from the mandible when we saw her in the office. So it's about 3 centimeters in size. The scan does not do it justice, but I promise I put these images here for a reason. And I'm not sure if the cursor is showing up here, but it's at the left anterior aspect of the oral cavity, just adjacent to the oral commissure. There's no mandibular erosion on her scan at all. And but there's just a couple of representative images here. And I just wanted to get a general idea from the group about what your general considerations are at this point in time. As I mentioned, the lesion is a little bit, still remains mobile from the mandible itself. But in terms,
do you have a clinical picture, or did you?
I will in just a second here, actually.
Oh, okay. Do you have an MRI?
I can skip ahead actually if you want a clinical picture. She ended up progressing considerably in terms of cutaneous involvement, but the lesion was just inside the gingival buccal sulcus.
Okay. So the lesion starts in the oral cavity.
Correct.
When you see it.
Correct.
And it's when you feel it, it moves along the mandible, against the mandible?
Yep.
I see.
Avinash, she is edentulous in the lower back.
Exactly. Yeah, she is edentulous, and
Okay.
I think the reason
that's an important factor in deciding what you want to do with the mandible.
Yeah, absolutely. Dr. Shaw, can you elaborate on that? Do you mind just providing your insights as to why?
So I think, if you are thinking about marginal mandibulectomy, you need to see the location of the alveolar crest and the mandibular canal.
Right.
Because as you get older and the mandible becomes edentulous, the alveolar crest recedes, and therefore the distance between the alveolar margin and mandibular canal becomes shorter and shorter.
Yeah.
The mandible does not recede concentrically; it recedes only the alveolar crest. Actually, a number of years ago, Steve Arian did a study on 32 mandibles, and he showed that regression takes place of the alveolar process, but the distance between the inferior alveolar canal and the lower cortex of the mandible remains constant at 11 millimeters. So you don't lose the mandibular height below the canal, but you lose the mandibular height above the canal. Now, if that happens and you do marginal mandibulectomy, you are going to wind up taking the mandibular canal with you in your marginal mandibulectomy, and therefore your remaining edentulous mandible will be avascular because of the endosteal blood supply gone, more avascular because of you raise the cheek flap, and therefore there is a high risk of pathological fracture. And if you are going to do that, then you have to support that mandible with a plate, either a mini plate or a reconstruction plate, depending upon how much soft tissue you have available.
Yeah, and I think you bring up the exact point that I wanted to make, which is great. And there's additional images here. You can see in a sagittal view, the vertical height of her mandible is right around 1.5 centimeters in an edentulous mandible. And I think this is just a scout image, but you can essentially see this is basically just a blade of mandible, and that's all that you really have left.
Steve, what's your approach to the edentulous mandible? Dr. Wang?
Well, I agree completely with those points. Is the edentulous mandible, and basically, I mean, to just sort of summarize that, you have less to work with, and so the likelihood of being able to do a marginal is much less. There are some advantages though, and the fact that if it's long-term edentulous, so there aren't tooth sockets that are there, then if the lesion is truly mobile with respect to the mandible, then it may not be necessary. I mean, that may mean that the bone is not involved, and you could do a soft tissue resection without having to take any mandible at all. So I mean, it's a little bit depends on both my physical examination as well as the imaging. But I mean, if there's not bone involvement, an edentulous mandible, it's probably going to either be no mandible at all or a segmental. But I agree, marginal is probably not an option. Right.
Yeah. So you raise a great point, and this is one of the dilemmas I always have. If we do that without removing the mandible, even if it's movable, and you go and you take the periosteum as your margin will never be 5 millimeters. It's going to be 1 or 2 millimeters. You might be negative margin. I have done it. But then how are you going to take your radiation oncologist away and the medical oncologist that's going to be blasting this woman with 70 gray because of closed margin and adding cisplatinum and killing her ears?
Well, so I mean, a soft tissue flap may help somewhat. So if you don't need a bone free flap, but a soft tissue flap may help in terms of preventing that complication. But I also, in our discussions, I mean, I actually think, I mean, bone is actually a pretty good barrier, and so even if it's less than 5 millimeters, but it's clearly, if I've intraoperatively clearly found that the bone is not involved. Then I'm actually not worried about that particular margin, even if it's less than 5 millimeters.
Yeah, I agree, and that's the point I'm trying to raise. That really talking to your radiation oncologist and medical oncologist is very important here. If you know that margin is clean, it doesn't necessarily make the patient to have adjuvant chemotherapy. Okay.
And I would add to that essentially you want to be in a situation where you've prepared the patient for the most maximally involved thing ahead of time. And so to Dr. Wong's point, certainly there's a chance that you're able to get away with a soft tissue resection alone, but you certainly want to have that conversation about getting your angiogram ahead of time, and a full segmental resection is needed based on your intraoperative findings. And so the patient came into the OR 3 weeks later with significant progression, including, these were not dermal metastasis, just as an FYI, this was direct tumor extension. And it may not show up as well on the picture, but this tumor started to creep up and over and down the alveolar ridge to essentially involve the buccal surface as well as the lingual surface of the mandible at this point in time.
So you have direct invasion to the skin?
Direct invasion to the skin, exactly.
And you know that this is oral cavity, correct?
Correct, yep.
So by definition is T4A.
Correct.
Okay.
And so she would need a composite resection of her buccal space, the facial, submental skin, the oral commissure, and of course a segmental mandibulectomy at that point in time. There's not really any question. Sorry, go ahead.
Yeah, go ahead.
Okay,
that's fine.
In this situation, this is just for the sake of discussion. There's no VSP available. And I wanted to get a sense from the group of what mandible plating options you would consider, how you would manage preservation of the mandibular position in space, or how you go about things intraoperatively in this scenario.
Great. So let's ask Chase. Chase, how would you approach these recons?
Yeah, it's a great question. In my short experience, the things that I've used in this scenario, when we don't have VSP, are a prevent plate. Synthes makes a couple of those. Obviously, it's a little bit of guesswork with no teeth to line things up. Stryker's doing the same, and they're also starting to make prevent plates now. So I would go with one of those and do my best to put the patient in what their occlusion would be if they had teeth.
Do you consider doing MMF after the tumor is out just to get a sense, or how would you measure your bone defect?
I'd measure it from the specimen.
From the specimen, okay. Ilya, you were working with Dr. Erkin. I guess he could do this by his eyes closed. So how would you guys do this?
Well, I wouldn't stress too much getting the perfect alignment here. She's a dentulous. I don't think she's necessarily going to notice if you're off by 5 millimeters or so. I would take her chin point midline, push it up against her columella, kind of line that up, and then bend the plate to the defect. I think what Chase said is once the tumor is out, just taking a ruler to what that segment approximate length is. But I wouldn't stress getting her into perfect alignment here. I think as long as you don't let the chin drift too much.
How would you approach designing your flap for the soft tissue defect?
So is my understanding that you weren't planning on doing a bony reconstruction?
No, we likely were. Yeah, the fact that it was immobile up front is really just kind of for the sake of discussion here. I think from the start we knew that we were likely doing a segmental, but any shred of doubt about that was eliminated when she came in with pretty significant progression over the course of a couple of weeks. So yeah, we were prepared to do a segmental resection on a bony flap.
I think this is a really hard reconstruction to do functionally with the oral commissure involvement. and I don't feel like I've ever done an amazing job with this, with an external defect, internal defect. I would probably, given that she's older, you might want to avoid the fibula for her gait issues and just do a scapula, and you can get some skin paddles. You can get latissimus, and you can get subscapular skin paddle, and try to do internal, external. You could also just put the fibula skin inside and then cover everything with a PEC. Those would be just my thoughts. But I think just with a fibula alone, and I've tried this where I curve the skin paddle around, and it's really difficult.
So,
Yeah,
Ilya,
the problem with the fibula.
I have David's point of view, just for the sake of discussion. What is the goal of a fibula-free flap in an 80-year-old edentulous patient with atrophic mandible and a T4 tumor?
Yeah, I think that's a great point.
This woman's median survival time for 2 years is less than 20%. With the extent
We have
of
immunotherapy now,
right
Dr. Shah. What are you talking about?
I'm sorry?
We have immunotherapy now. What are you talking about?
Sure.
It cures
Yeah.
everything.
I don't think I will live long enough to see the long-term benefit of immunotherapy. So the issue here is you want to get this patient in and out of the operating room as quickly as you can, as safely as you can, and keeping her commissure competent. I think bone reconstruction and aesthetics is a tertiary priority in this situation. And I would be inclined to, just to stabilize her mandible, put in a reconstruction plate and a two-pedal folded radial forearm free flap, which will give you inner lining as well as exterior lining, and will cover the reconstruction plate. And you will have accomplished the goal of maintaining the mandibular arch. You will have provided exterior and interior lining, and you would have restored her commissure. The commissure doesn't need to be taken too much, as I can see from the picture. So you will still be able to maintain oral competency. But this is what I would propose to do.
Sure. The problem, so, okay, let's see. Chase, what would you do for soft tissue recon?
So I was all prepared to do a fibula after or prior to hearing Dr. Shah, but I totally agree now. I think a bar and then I'd do a folded ALT. That'd be my preferred soft tissue recon over a bar.
ALT would be great.
No,
So we are all doing
There's a
free
comment.
flaps. Why not do a fibula? If you're doing if you're doing a PEC flap, you can say, okay, there's no anastomosis, in and out, and the PEC is, God knows, is big enough to cover everything. It's not going to be beautiful, but I don't think we are doing beauty contests. If you are doing a free flap, I mean, the difference between a fibula and ALT is not that much.
And I agree, and with the forearm as well too. I think it's either you do a free flap or not, and then which one of those I think to some extent is, I don't know that it makes as much of a difference, but certainly the degree of extension to the anterior mandible. This lady is very spry, healthy, and she's up for proceeding with radiation. She's very active. She raises her grandkids.
I see.
So
I see, Dr. Wee turn on the camera, so that means seriousness. All right, Don, what would you do in Miami?
Again, I think the answer to your question, which is why I turned on the camera, is I think a PEC flap in some ways is quicker, but in reality, it's not that much quicker, and it is definitely going to pull that commissure south. I think and she doesn't look super thin, so I think it's going to be pretty bulky. I think if you're not going to recon the mandible but put a bar, I actually would use a forearm just because it's going to be the least bulky, least likely to pull south. I think an ALT is going to give you more protection of your plate, but I think it's going to have some of those bulk issues that she just looks like she's not got the best. Based on her shoulders, I'm afraid her legs might be comparable.
That's a great
Dr.
point.
Weed,
Yeah,
you're describing everybody. You're describing everybody in the state of Indiana currently.
Don, I tend to agree with you completely. We did a study of 232 pectoralis flaps published in 1986, and oral cavity was the worst site for PEC flap. It's against gravity. It pulls away, pulls the commissure down. And if you have a metal inside, it's going to expose the metal and create more problems and invite a second operation. So I would be dead against a pectoralis flap for this particular reconstruction.
All right. So, Avi,
Yeah.
for the record, I'm with you. Actually, I think fibula is if you can do this, two team and quick and with reasonable morbidity, I think fibula. There's nothing wrong with fibula. Go ahead.
I think particularly with an anterior defect in a patient who will get
Yeah.
radiation, I get a little bit more concerned about the possibility of a bar exposure and contracture around it. And I want to bring this case up because there's a lot of different options as far as the mandible goes, and when you get this much soft tissue involvement around it, the external fixator is something that not a lot of people train tremendously on around the country all the time, but it's something that we have found that we use a pretty significant amount. The external fixator is a great option regardless of the availability of VSP. It looks intimidating because it's like a million rods and pins and you're like, what am I doing with this thing? It takes about 5 minutes. So it does not add a whole lot of time, particularly in lateral defects where there's not really much characteristic bony surface changes when you put into a VSP model. And again, we wouldn't use VSP in this case necessarily. This patient doesn't have teeth, and as Ilya's point is a great one, right? If you're off a tiny bit, this is not something that anyone's really going to notice. So it's not something we necessarily stress about too much. But for other patients, say, who do have teeth, even if you do everything right from a VSP standpoint, you get enough rotation in the condyle that you've done everything right. Your cutting guides work perfectly, and the patient wakes up and they've got malocclusion still sometimes when there are not real good characteristic surface landmarks in the lateral aspect of the mandible going up the ramus. And so just something to keep in mind in a edentulous patient with very low mandibular height, you are putting a couple more screws in there. So you want to be aware when you're putting the rods and pins in, but I wanted to bring it up for that reason. This is what we end up doing in this case. She needed a mandible section that ended up going pretty far anterior. So you get the bone exposed on either side. I'll just burn through these quick so we can continue to talk about this. I said,
did you take the commissure and the lip?
We took the commissure and the lip as well as the skin around it. Yep.
Okay.
Basically, all you do is you drill 2 pins into the mandible on each side, and you hook up your rods, which are carbon fiber nowadays, probably because they're more expensive, and that's how plating companies work. But you secure everything together pretty slowly, and then when you do your segmental, your mandible is where it should be, and you just plate to the residual mandible there where it's left over, and then take your external fixator off, and your mandible position and space should be preserved the way that it was pre-morbid. So the external fixator is just something I think don't necessarily rule it out. It's something that I think is, as I mentioned before, not a lot of people use a ton in the training programs, but it's something that we found a ton of utility on, especially in this patient population.
Sure.
And I was wondering, just out of curiosity, maybe not necessarily as we talked about bone flaps or non-bone flaps, is there a minimum bone segment length that you guys generally shoot for, and whether or not you tend to deproject? One of the challenges I've had with the pre-bent plates is that they're bent to the native mandible. And so you sometimes end up with these symphyseal segments that are, 1.5, 2 centimeters, and that can be very challenging. I didn't know if anybody had any comments on that.
Well, it's 8 o'clock, so we have to finish this great case. And I just want to say, that 5 minutes for that external fixator is like 3 centimeter in California bone. So that's going to take more than 5 minutes.
I tell you, yeah.
Your point well taken, and kudos to you guys to do that. That's beautiful work, really. And I completely agree with you that we should all think about these options. But please humor us and move your case forward so we can finish.
Yeah, and I'm just winding down right now. Is really those questions from a mandible management standpoint and reconstructive standpoint.
So this is
using fibula. Yep.
Double skin paddle
inside
outside.
We used the fibula. We used 2 separate skin paddles. We had 2 perforators, so we could divide it down the middle for one inside and one outside. And we ended up closing the commissure on itself, and she's maintained her oral competence since that time. So,
yeah, I think it's a great illustration of really breaking the defect down into the different components. It's so easy to try and say, how do you make a free flap repair that whole thing, or a regional flap, and kind of the way you guys had addressed the lip component and kind of looked at. There's a component of this is lip repair, and then there's a component that's inner, outer, and mandible repair. And, as Dr. Shaw pointed out, the functional implications of, putting in, immobile free flap draped over the corner of the mouth or off, they're awful. And I think the quality of life have been terrible, but I think using the native lip in the way you did will really give that patient the best result. And I think the point that you made about deprojecting is really crucial too, because you're not going to have the same soft tissue envelope, a large profile plate that, oftentimes has to be used in some of these. That gives you that chance to bring it back. So I think it's an excellent job.
So congratulations.
Yeah,
It's a very impressive case. I had a question, because you mentioned that you were able to do 2 skin paddles because you had 2 perforators. Prepared to have alternatives if you weren't able to get enough skin for both the external and the internal defect?
Yeah, we were. She had a good AHNS test. So we in these cases, we usually end up prepping multiple donor sites if we need to. And of course, the scapula is perfectly available as well too. And so sometimes the nice thing early on in a fibula is all you're doing is you're making your first incision and you'll see your perforators right away. And so if you felt like you didn't have the opportunity to get enough soft tissue from a fibula skin paddle, then you could essentially close it without a whole lot of morbidity and move on to a different donor site altogether if you needed to.
It also looked like since you closed the commissure on itself, you might have been able to do a local advancement for the external defect if you had to.
Correct.
Design your neck incisions, in a way that would accommodate that, but that would be another thought.
Yeah, I think that another excellent case, a lot to learn. The one thing I would say as someone who's trying to do these things, these are hard. And these are not, Avi and Mike make it look easy. They do a freaking external fixator in 5 minutes. So you imagine how good they are. But these are hard cases, amazing work. And I think Mike's point was very important that you have to break down these defects into multiple subunits. How are you going to reconstruct the lip? How are you going to reconstruct the mouth? How are you going to reconstruct the bony? How do you reconstruct the neck? And there is a lot to be said about these things. I think there are a lot of good commentary from the panel, especially that, what's the goal of reconstruction? And what I would say is, I think what we are all trying to say is do what you think is the best and you can do the best. And you have to meet both criteria. Okay, well, it's 8:03. Thank you, panel, for an excellent case. Honestly, any of these cases could have filled the entire hour. I really thank Chase for arranging this amazing panel and discussion, Dr. Ilya Viktorov, Dr. Avinash Montraverdi, and our panelists, Dr. Steve Wong and Dr. Shah. And thank you for the guest appearance from Dr. Reed and our own in-house experts, Jeffrey Liu and Michael Moore. We'll see you in 2 weeks. So I hope you can join us. Have a great night.
Thanks a lot. That was awesome.
Thank you guys very much. Appreciate it.